So this patient has chronic recurrent iritis and has had prior cataract implant surgery. You can see some capsulorhexis contracture here, but her problem is glare, and that's her normal pupil. So it turns out that if you examine patients like this, and in the lane, if this is her right eye, if she takes a card, or I do, and we bring it up like that, her glare goes away, okay? Because that's the largest part of her pupil. She's got some funky capsule there. And so what I'm actually going to do is an inferior iridoplasty. I'm going to suture her so that I can get the edge of the pupil to come close to that inferior part of the lens, the anterior capsule. So be suturing something like across here. She obviously cannot use miotics to make her pupil smaller with her recurrent iritis history. All right, so I'm going to make a side port blade opening right around here, about so in length, and let's put some OVD in her eye. Now, I'm going to use the Siepser technique, which is described by Stephen Siepser, but very well depicted by Dr. Robert Osher in a JCRS article some years ago. So the key is, there are a number of them. First, I'm going to introduce the suture. And saw that little jab? That's how you get through. You create inertia. Because if you don't do that, you can put traction on the iris root. Now I'm lining up this side, and I'll do the same thing as soon as I'm comfortable that I got it just right. Yeah, looks pretty nice. You want to get a good piece of iris there. Good. And that goes right out the other side. Okay, so I'm going to now pull that through, and I'm going to rotate the globe towards me. This patient has been blocked so that I can not hit the nose as I pull it through. And we'll see, that might be the only suture we need. We may need another one. Of course, I haven't tied it yet, but here we go. Quickly. So I'm going to pull the suture mostly through until I see the end of it here. And then I'm going to hold this end over here, and I'm going to go grab that part and bring it out of the eye. Now as you do this, you want to be sure that you don't pull hard on the iris root, meaning that the suture slides right along easily. Okay, so now there's the loop. Let me set this thing, that end down, and the top part will go to my right, and the bottom part's going to go to my left. And now you verify that the bottom part, this right here, goes to the iris. So when I pull on it, the iris moves. See that pretty easily? Okay, so now I got to wrap this around that time. So I'm going to hold up this end and pass this through it. Once, twice, and 3 times. Now, I'm going to pull on both of these ends. The knot will go into the eye. Wet the cornea, please. and will oppose those two parts of the iris. Right where we want it to. Okay, now we've got to repeat that maneuver, although the second time requires only 2 throws. So now we're going to go in and do the same thing. Going to go retract that loop. Watching that the thread comes easily, so there's no traction on the iris root. Bring the loop out. Bottom part goes to the left. Top part goes to the right. You can verify that the bottom part goes to the iris by pulling on it, but it has to go to the iris. And now we'll do the throws again. And this time it'll be just 2 throws. So I've grasped the short end, the cut end, and I'll pass it through there twice. So I've got a 3 pass and now a 2 pass. Wet the cornea. And I'll cinch this down. And then I'm ready to cut the suture. Now I'm going to make a little inferior side port blade here, opening. I'm going to use that to just cut the suture free. Because if I tried it through this incision, it would be the wrong angle of approach. Let's see if that's even big enough. Let me have a small Honda scissors. Let's see if that fits better. So I'm going to introduce this small scissors here and just cut the 2 ends. Okay. So now we're left with that small opening there, and I'm going to close that too. Now you might think, oh gee, is that lily gilding? No, because if we don't close it, what happens is tail light diplopia. When people are out at night, they'll get a second image of tail light and maybe even glare from headlights. So I'm going to do the same thing you just saw me do a minute ago. Same technique, identical. And close that little area and we'll be done. So I'm going to hold on to the proximal end of the suture, insert the Kugel, retract the loop, and then flip it so that the bottom side is down again. Tie. Prove that the bottom side is down by pulling and seeing the iris move. And here we go with, you know the drill by now. Going to pass it through 3 times. There goes our second one. A little capillary attraction of fluids there. And our third loop. Snug it down, closing the iridectomy. Wet the cornea. You can see the loop there. Not easy to see on this very deeply pigmented iris. And then the coolant again. And there's our loop. So we'll pass this around here twice. Now if you're in doubt, gee, did I do it twice or not? Am I positive? You could do it a third time. I just did, or am doing it. And then it remains only to cinch this down. And now we'll use the scissors. So finally, cutting the sutures free of the knot. Let's see if that's free yet. Nope. There we go. Syringe VSS. So now I'm just going to irrigate the OVD from the eye. Make sure both incisions are tight and not leaking. In this patient, I'm going to give a subconjunctival Decadron injection. Because of her history of iritis. And that's 4 milligrams, 1 cc of Decadron, and we're done.